cloxacillin, cephaloxin, erythromycin and clindamycin. So these are the agents. Cloxacillin, cephaloxin, erythromycin, clindamycin were not a good drug of choice for any type of bite, animal bite or human bite. Only amoxicillin, ampicillin, sulbactam for mild to moderate infection. If the moderate to severe infection, ertapenem or any carbapenem is the drug of choice. So we have to go with the amoxicillin. Okay. Move on to the next case. 82-year-old female, burning maturation, no loin pain, no fever. So we are dealing a case of uncomplicated urinary tract infection. So this is the culture report. You can see ampicillin, cephaloxin, cefuroxime, cefotaxime, almost all penicillin, first generation, second generation, third generation cephalosporin resistant. Your people is also resistant. You can look at BLA were susceptible, imipenem, meropenem and amikacin, carbapenem were susceptible. So we are dealing a case of ESBL producing E. coli sensitive to carbapenem and BLA. With this we can choose uncomplicated UTI. So we can choose nitrofurantoin as the drug of choice. In our state guidelines, we give in definitive therapy guidelines as the fourth chapter. This chapter will guide you to assist to select antibiotic after your culture report care. So this is the third generation cephalosporin resistant. So uncomplicated cystitis, nitrofurantoin, portrait, if susceptible, we can use. If pyelonephritis, so carbapenem, kefipain, inhibitors, bacter should be used. Outside the infection, carbapenem is the drug of choice. Carbapenem is the drug of choice. So bacteria, already said, asymptomatic bacteria, no antibiotic, only two conditions, pregnancy, before urological surgery, you need to treat. Otherwise, even culture positive, 10 to the power of 5, without symptoms, no need for antibiotic in asymptomatic bacteria patients, except pregnancy as well as urological surgery. So for our patient, we need to go with the nitrofurantoin. If you think this is the culture report, so an asymptomatic bacteria patient has no symptoms, no antibiotic is needed. If the patient has to go for some urological procedures, you need to go with some antibiotic, that is cotrimoxazole is the very good drug of choice. Uncomplicated cystitis, nitrofurantoin. If the same report in a case of pyelonephritis without bacteremia, no blood culture positive but urine culture positive, we can go with the beta-lactam inhibitor combinations. In the same patients, blood culture also positive with the same nature, you have to either go with the carbapenem, ertapenem or meropenem. If the infection is outside the urinary tract, you have to go with the carbapenem only. So same culture report, different type of patients, we need to choose antibiotic according to the patient symptom. So same report, same drug cannot be used for all these type of patients. So we will move on to the next case. 40-year-old diabetic, urinary tract symptom, no loin pain, no fever. So uncomplicated cystitis, culture grew, enterococcus species 10 to the power of 3, that is ampicillin, nitrofurantoin, vancomycin resistant. So vancomycin resistant enterococcus, phosphomycin and doxycycline is only susceptible in our case. So what will you choose? Either ampicillin, vancomycin, both were resistant, oral phosphomycin as doxycycline. Previously we saw all macrolides, tetracycline, no renal excretion, so doxycycline should not be used. So in enterococcus species, we have to use the terminology, that is tolerance. Tolerance means even the antibiotic is susceptible in vitro. Enterococcus may develop resistance during the treatment period. So that is the tolerance. So tolerance is the only word applicable to the enterococcus species. So this is we can easily identify according to the culture report whether it is enterococcus picalis, species, caseolus, carinara, along with these treated ampicillin, quinine, doxycycline and vancomycin. So these are the agents. Enterococcus are intrinsically resistant. So all cephalosporin, cotrimoxazole, clindamycin, aminoglycosides, asteroma and cholesterol, enterococcus were intrinsically resistant. But even enterococcus is resistant to ampicillin, and the single gram of ampicillin will result in almost 1500 to 3300 microgram ml of concentration in the bladder. So even if ampicillin is resistant in a case of uncomplicated UTI, even in a case of vancomycin resistant enterococcus, ampicillin can be chosen to treat this patient. If the patient has complicated urinary tract infection, same culture report, we have to go with linezolid. So this is from the antimicrobial agents chemotherapy, and also on the Harrison, you can look at the bottom, urinary tract infection, vancomycin, ampicillin, nitrocondyl for enterococcus fecalis, for even vancomycin as well as ampicillin resistant enterococcus faecium, urinary tract infection, you can see ampicillin and amoxicillin. What also Harrison says, even the MAC of ampicillin is more than 64, we can go with 12 gram per day of ampicillin to treat uncomplicated cystitis, which ampicillin as well as vancomycin resistant enterococcus causing the infection. So we can go with ampicillin 12 gram per day. So which of the following infection is difficult to treat when the infection is caused by ampicillin susceptible, vancomycin susceptible enterococcus fecalis? So bacteremia, uncomplicated cystitis, chronic prostatitis, meningitis. So ampicillin, vancomycin susceptible enterococcus fecalis, bacteria, prostatitis, meningitis, cystitis. So what Harrison says, prostatitis, the prostate is the area glycopeptide as well as aminopenicillins were very less penetrating power. So even if the organism is ampicillin sensitive, vancomycin sensitive, if you treat chronic prostatic infection with either ampicillin or vancomycin, the results will be not very good. So we have chronic prostatitis is the very difficult one to treat. So even ampicillin resistant infection confined to the bladder, if it is enterococcus, we can give ampicillin. Even ampicillin resistant or vancomycin resistant enterococcus, ampicillin sensitive enterococcus in a prostatic infection, because of very poor penetration, it is difficult to treat. Move on to the next case. So which of the following infection caused by direct invasion of staph aureus infection? So meningitis, UTI, pneumonia, SSI. So all other three, meningitis, pneumonia, SSI, direct infection causing infection, but UTI only hematogenous spread will cause the urinary tract infection. So what is the implication? If you send the culture report, if the culture shows nitrocondyl susceptible, so that would be not the good drug of choice treating Staphylococcus aureus urinary tract infection. So you have to treat the drug will also dealing with the bacteremia of the Staphylococcus aureus infection. So nitrocondyl, if the culture report says positive, you should not use for Staphylococcus aureus urinary tract infection. Other thing, if the tertiation cephalosporin sensitive, cephaloxin, ceftriaxone, they are not a good drug of choice to treat any urinary tract infection because they have very less urinary excretion, only 30% excretion. You are giving cephalosporin, ceftriaxone susceptible E. coli. I am starting with the cephaloxin, patient doesn't respond, means ceftriaxone where only 30% urinary excretion. So do not use these two cephalosporin to treat urinary tract infection. Cephaloxin is the good drug of choice for if it is sensitive. That's a good drug of choice in treating urinary tract infection. So hematogenous. So do not use nitro and vancomycin even sensitive in a case of Staphylococcus urinary tract infection. So which of the following is the carbapenem sparing antimicrobial? So what is the meaning of carbapenem sparing antimicrobial? So even if the BLBLA were resistant, this BLBLA will almost has the carbapenem potential, like it has very good activity of ESBL as well as AMC. So both BITAS and Cercoris and Celbactam, no AMC action. Peropenum is not a carbapenem, or it's only penum, so it has no coverage like carbapenem. So Clefepime enmetosabactam has very good potential over ESBL as well as the AMC. So that is the carbapenem sparing beta-lactam inhibitor combination. So capecium inhibitors bacter, you can see in our guidance pyelonephritis and complicated urinary tract infection. So capecium inhibitors bacter. So now we have automated culture system in our microbiology lab. So in future, vital report may generated for any mostly blood culture as well as the urine culture for ICU patient. So there are two very good journals. We can able to identify up to the genetic level of carbapenem resistant. One is from the Mayo Clinic emergency insulin gram-negative bacterial resistant, in which you can see three drugs. One is third generation cephalosporin, osteonol, as well as your ceftazidime avibactam. If third generation cephalosporin were susceptible, osteonol may be susceptible or resistant, but ceftazidime avibactam also susceptible. That means we are dealing a case of oxa 48 enzyme. If osteonol resistant, osteonol susceptible, ceftazidime avibactam resistant, we are dealing a case of MPL producer. If osteonol resistant, ceftazidime avibactam susceptible, we may dealing a case of KPC producer. If the organism is producing that particular enzyme only, we can be able to identify presumptively. If the organism is producing KPC plus oxa, NDM plus oxa, we won't be able to see this kind of report from our vital report. This is another journal. We can see in Klebsiella pneumoniae, meropenem potentiation by the meropenem aboribactam. Even though meropenem aboribactam is not available in India, there is strong potentiation in our culture report. So then oxa 48, high resistance of penicillin or piperacillin consobactam. So with this we can be able to presumptively identify which gene present in our sensitivity report. If the carbapenem is resistant, look at ertapenem resistant, meropenem resistant and imipenem resistant. Then look at ceftazidime avibactam susceptible and your meropenem aboribactam susceptible, your osteonol resistant. So meropenem aboribactam susceptible, ceftazidime susceptible, osteonol resistant. So what it could be? KPC producer. So KPC producer, meropenem aboribactam will potentiate the meropenem action. So meropenem single itself, MAC is 8, meropenem aboribactam, you can see the meropenem MAC is 2. So meropenem MAC is potentiated with the add of meropenem aboribactam. So this is the next one. You can see ceftazidime avibactam susceptible, osteonol, presume it is a resistant, sensitive, osteonol resistant, meropenem aboribactam is sensitive. So what it could be? Meropenem aboribactam sensitive, ceftazidime avibactam susceptible. What it could be? KPC or oxa. So always look at the meropenem aboribactam. Is there a potential? Look at meropenem MAC is 4, meropenem aboribactam MAC also 4. There is no potential. Only ceftazidime avibactam is susceptible. So we are dealing a case of oxa 48 enzyme. You can look at the piperacillin more than 64. That's the highest of the all available here antibiotic. So piperacillin tazobactam, high resistant 128, third generation cephalosporin susceptible, imipenem and meropenem they are resistant. So we are dealing a case of oxa 48. You get osteonol susceptible, carbapenem resistant. Osteonol susceptible, carbapenem resistant. So we are dealing a case of NDM producer. So if these culture reports, if the organism is having that single type of gene, we can able to detect if KPC plus oxa, if NDM plus oxa, if KPC plus NDM, we cannot able to see this much of influence from our culture report. Then move on to the next case, 33-year-old male, IV drug user, 3 days fever, all features seen as here, infective endocarditis, our blood culture grew, Staph aureus, 3 cells, all the 3 cells grew, Staph aureus, this is our culture report. Penicillin, suboxylin resistant, ciprofloxacin, tetracycline, erythromycin resistant, linezolid, cotrimoxazole, clindamycin, sensitive, vancomycin. Even with culture report, we can able to say the MIC, 1 microgram, that's also susceptible. So cefoxylin is the surrogate marker of MRSA. So our is MRSA. So only linezolid, cotrane, teicoplanin, clindamycin were sensitive. So how will you proceed? Linezolid, vancomycin, daptomycin, teicoplanin. So this is our valence A. So methicillin resistant, vancomycin sensitive, Staph aureus for bacteria, vancomycin and daptomycin are the first line agent or drug of choice, followed by your ceftaroline. This is the definitive therapy guidelines starting for ESBL, carbapenem resistant enterobacteriaceae, Pseudomonas aeruginosa are difficult to treat. Then you have carbapenem resistant Acinetobacter baumannii, Staph aureus, MSSA, SRSA, treatment option for P. caulis as well as PCM, definitive therapy for infective endocarditis, definitive therapy for fungal endocarditis. These are there in our state guidance book. So we have to go with either vancomycin or daptomycin. This is the drug of choice for treating MRSA, infective endocarditis. If there is no valve involvement, 2 to 4 weeks duration of treatment is enough. If there is valve involvement, at least minimum 6 weeks duration is important for Staph aureus infective endocarditis. If Staph aureus isolated from the blood, we have to take after 3 days again a blood culture to view whether our antibiotic is working for the patient or not. We need to take repeat culture for Staph aureus after 2 to 3 days of treatment of Staph aureus bacteria. Then another one point, among these 4 agents, vancomycin, linezolid, daptomycin, teicoplanin, linezolid is the bacteriostatic agent. It should be combined with some other drug. If you are using linezolid, other 3 drugs, vancomycin, daptomycin, teicoplanin has the very good BMQ quotient compared with the vancomycin and daptomycin. What is BMQ? Breakpoint to MIC quotient. So if the teicoplanin is susceptible, we can go with the teicoplanin directly. If the teicoplanin is not susceptible, go with the vancomycin and daptomycin even for bacteria and endocarditis. So this is the next case. It's a Marganella margagni. You can see amoxiclav resistant, ampicillin resistant, ampicillin sulbactam resistant, cephalosporin resistant, peptide sensitive, tetracycline and tetracycline. Tetracycline susceptible, tetracycline susceptible. So amoxiclav, cephalosporin, tetracycline. So tetracycline is the latest tetracycline group, but it is resistant, but the tetracycline susceptible. Third generation cephalosporin susceptible, peptide susceptible. Is our antibiotic report is correct or incorrect report? Is it a ESBL? ESBL means up to third generation cephalosporin should be resistant. AMC also third generation cephalosporin should be resistant. So is it incorrect report or none of the above? So our state guidelines has intrinsic resistance chapter. If you look at Marganella margagni, ampicillin, amoxiclav, first and second generation cephalosporin, tetracycline, metoprolol, colistin and colimixin were intrinsically resistant. So these drugs should not be reported and these drugs should not be used to treat Marganella margagni infection. So tetracycline resistant, but a tetracycline susceptible for Marganella margagni. So we are dealing a case of intrinsic resistance of Marganella margagni. So these are some other intrinsic resistance present in our book chapter. So this is the intrinsic resistance. So match the following. So think this is the Pseudomonas aeruginosa infection. This is the MRSA infection. This is Enterococcus faecalis. So the number 1 could be a agent that is covering Enterococcus faecalis, MRSA as well as Pseudomonas aeruginosa. Number 2, that should be cover only MRSA as well as Enterococcus faecalis. Number 3, that should cover Enterococcus faecalis as well as Pseudomonas aeruginosa only. 4, Enterococcus faecalis coverage only. 5, Pseudomonas coverage only. 6, MRSA coverage only. No other drug coverage. 7, no coverage for all these drugs. So ertapenem, clindamycin, astriona, ampicillin, peptide, vancomycin and gentamicin. So what could be the match? So we have in our antimicrobial therapy, there is a antibiotic activity spectrum chapter. In that chapter, we put some red indication, no use, either green or blue or yellow, that can be used for that particular organism. So Enterococcus faecalis, aminopenicillin, BLBLA, carbapenem, especially imipenem, ciprolivo, levofloxacin or moxifloxacin, gentamicin for infective enterocolitis can be used. Likewise, other drug for gram positive, gram negative, there are 2 tables. Then non-fermented, there are 2 tables. So these are the antibiotic activity spectrum. So if you combine all the drug I have presented, ertapenem, no coverage with the Enterococcus faecalis, MRSA or Pseudomonas, clindamycin only has MRSA coverage, Osteonum only has Pseudomonas aeruginosa coverage, ampicillin, Enterococcus faecalis coverage only, Piptas, Enterococcus faecalis and Pseudomonas aeruginosa coverage, Antimicrobial faecalis as well as MRSA, no Pseudomonas aeruginosa coverage, gentamicin for prosthetic wall infective enterocolitis. If it is high level gentasensitive, Enterococcus faecalis we can use along with other drug. MRSA for infective enterocolitis we can use. Pseudomonas aeruginosa also we can use. So gentamicin is the only drug we can use for all 3 bacteria. So with the antibiotic activity spectrum in our chapter. So in reversing order 7, 6, 5, 4, 3, 2, 1 is the answer for the match of the following. Then move on to the next case. 30-year-old female, ESBL producing Klebsiella bacteria. So ESBL, Klebsiella, that is 3rd generation cephalosporin bacteria. So what would be the drug of choice? On our treatment guidelines, all 3rd generation cephalosporin only carbapenem. So we have to go with either meropenem or imipenem or ertapenem. So this patient we started with the meropenem. So creatine clearance is 5. Creatine is 5. Creatine clearance is 40 ml per minute. So we need to go for some lower dosage for creatine clearance. So whether meropenem 1 gram PAD or meropenem 1 gram BD or meropenem 0.5 gram BD or meropenem 0.5 gram OD. So which one I have to choose? This is our guidelines, table 7, dosage and tables and duration. You can check on the 4th column of our table. The first column should be more than 50. It wrongly interpreted as a less than 50. So loading dose followed by maintenance dose, TDS. 26 to 50 is creatine clearance, 12 gram, 1 gram, 12 hourly. If it is less than 25, up to 10, 500 milligram BD. So ours is a 40 ml per minute. So we have to go with meropenem 1 gram BAD. So any creatine clearance doses also we can check in our antibiotic state guidelines, antibiotic chapter 7. So meropenem 1 gram BAD for our patient we have to go. Then next case, a 24-year-old female craving 2 months of amenorrhea, fever with rigor and chills for 2 days. Purple sinus source, plasmodium falciparum infection. So any case, not pregnant, any pregnant patients. So first 3 months is the total pregnancy period is very risk for antibiotic. Among these, the first 3 months where we have to target which antibiotic should not be given, which antibiotic can be given. So for this patient, which one could be the drug of choice? Artemether, lumefantrine, amiodarone, artesunate, mefloquine, artesunate, dietro, artemether with Dr.A.V.M. So which one should be used? We will look at our chapter. In our chapter, we have drugs in pregnancy. So these are the drugs contraindicated in first trimester of pregnancy: metronidazole, pindazole, cotrimoxazole, fluconazole, efavirenz, pyrimethamine, mefloquine. All ACT combinations like amiodarone, mefloquine and DHA-ibuprofen, but artemether, artemether lumefantrine can be used as per WHO as well as our national guideline for malaria. So this is the only anti-malarial group of drug can be used to treat plasmodium falciparum infection in first 3 months of pregnancy period. Then move on to the next case, a congenital heart disease patient comes for gingival procedure, infective enterocolitis prophylaxis. Which one to be given? Patient is resistant to penicillin. So whether it is a clindamycin or azithromycin or both, none of the above. So which one I have to choose? Look at our state guidelines. So if the patient is sensitive, amoxicillin is the good drug of choice. If the patient is allergy are able to take oral cephalexin, clindamycin, azithromycin, doxycycline according to the dose. In the dose without to give 30 to 60 minutes before procedure. If the patient is unable to take orally, IV preparations, sensitive ampicillin, cefazolin or ceftriaxone, allergy, cefazolin, ceftriaxone and clindamycin can be used. So for tooth extraction, yes, it is okay. Prophylaxis definitely needed. Surgery planned in the lower respiratory tract, planned on the skin. The therapeutic regimen that covers Streptococcus species as well as MRSA. No need for additional infective endocarditis dosage. Surgery planned in the GET tract. No need for infective endocarditis prophylaxis. So postgraduate, move on to the next stage. He is vaccinated with hepatitis B. His anti-HBs antibody titer is more than 20 international unit per ml. Has accidental lead injury with high viral load positive of hepatitis B patient. What is the post-exposure prophylaxis? High viral load positive hepatitis B. What is the post-exposure prophylaxis? Whether hepatitis C immunoglobulin already vaccinated, immunoglobulin only, or no vaccine is needed. No immunoglobulin needed to initiate the vaccine series, or both immunoglobulin as well as vaccine. No PEP required. PEP already coming into vaccine series. So which one is the answer? So if you look at our state guidelines, already documented responder. So what is documented responder? If the anti-HBs antibody titer after 2 months of your last dose of hepatitis B vaccine is more than 10 milli international unit, you are vaccine responder. No need to worry. Any type of hepatitis B infection that will not infect you. So you are the documented vaccine responder. More than 10 milli international unit. Almost after invention of hepatitis B vaccine, almost more than 30 years old, long period gone. No booster dose is needed so far. If more than 10 milli international, any point of single take, so your titer always will be protected for hepatitis B infection. No booster dose needed, not needed. If your anti-HBs antibody titer is less than 10 after 2 months of your last dose, you need to go for another 3 doses of hepatitis B vaccine. If the vaccine is after last dose of second cycle third dose, after 2 months, if you check your anti-HBs antibody titer, if it is more than 10, you are protected. If it is less than 10, you have to always carry in your pocket your non-vaccine responder. So you are the candidate for hepatitis B immunoglobulin. So always check your anti-HBs antibody titer after 2 months of your last dose. If it is more than 10, you are protected. If you are less than 10, second dose, then after 2 months, again less than 10, you have to always carry vaccine non-responder. You have to also tell your colleague about your vaccine non-responder. So you are the candidate for hepatitis B immunoglobulin. So no guideline for booster doses. Then which vaccine is not included in our national immunization schedule? So all vaccines are there except the pneumococcal conjugate vaccine is there in our national immunization schedule. Polysaccharide vaccine is not in our immunization schedule. So this is national immunization schedule also there in our guidance to antimicrobial therapy. So this is polysaccharide vaccine is not there in our guidance. So this is the funny one. Which of the following disease causing bacteria is always ready to toxin stage? So stage le endha bacteria syphilis causing bacteria, TB causing bacteria, leptospirosis causing bacteria, cytotoxis causing bacteria. Actually இந்த கேள்வியை எங்கள் வீட்டில் ஒய்ஃபும் பாப்பாவும் மெடிக்கல் சாம்பிள் கொடுத்தா 2 பேருமே ஆன்சர் வந்து சிப்ளிஸ் அப்படின்னு சொன்னாங்க. ஏன் அப்படின்னு சொன்னால் அதுதான் நிறைய ஸ்டேஜஸ் வந்து, அதனால் அதுதான் ஸ்டேஜ் வந்து சொல்லிட்டு, பட் ஆனால் ஆன்சர் வந்து மைக்ரோ பாக்டீரியம் tuberculosis. பேர்லேயே மைக் இருக்குது, அதனால் மைக்ரோபாக்டீரியம் tuberculosis. So to conclude, this is the antibiotic pipeline from 2009. So only 24 drugs were approved from 2019. 2009. Only 24 drugs. Among the 24 drugs, you can look only 7 drugs were active against carbapenem resistant enterobacteria. Among the 7 drugs, only 4 drugs were acting on metallobacter actinase. Why metallobacter actinase? India Southeast region is the country we were having high levels of metallo-beta-lactamase producing enzyme as a carbohydrate producer in our Indian sector. But unfortunately, all these 4 agents were not available in India. So we are dealing with the crisis against the metallo-beta-lactamase producer. Only 7 drugs, among the 7 drugs, only 4 drugs were metallo-enzyme producer. So this is the Kuser antibiotic book first edition during 1972, only 392 odd pages. Now Kuser 70th edition, almost 5,400 pages. So first edition to 7th edition, almost you can see the increased number of pages. So ICMR therapy, ICMR guidelines also released recently. It target fully on empirical therapy. Our state guidelines guide you in empirical therapy as well as definitive therapy, even after culture results, antibiotic activity spectrum, intrinsic resistance and antibiotic prophylaxis, which one to choose, we can able to see from our state antibiotic guideline. Again, I emphasize on hand hygiene, and you have to follow standard precautions to preventing the spread of AMR. So fighting AMR, always we have to be a part of the solution. Thank you.
Thank you for detailed presentation, sir. I think antimicrobial resistance is no longer a concern of microbiology department. It is the concern of every clinical department. Recently, we had 2 cases of sepsis. Both are post-LSES. So in the beginning, we used to give cefatoxime and gentamicin for all the post-LSES cases. And in patients with the high-risk factors, we used to give them ceftriaxone and amikacin. So those patients were already on ceftriaxone with amikacin, but both had high spikes of fever with pallidicilius. So we started them on piperacillin tazobactam. We waited for 3 days, but patient had again high spikes of fever with early involvement of other organ dysfunction also. So again we added injection linezolid. We waited for another 2 days. Then also fever not subsided. Then finally we gave them injection marapinum. So prescribing antibiotic to a critical cases like fighting in a battlefield. முதல்ல வந்து ampicillin gentamicin தான் we used to give. So initially கம்பு கொண்டு போவோம், அடுத்து like knife, then sword, finally gun. இப்போ மெரப்பினம் தான் எங்ககிட்ட இருக்கிற கன். இப்போ அந்த கன்னுக்கு பேஷண்ட் லைக் அந்த ஆர்கானிசம் இதாகலைன்னா, ரெஸ்பாண்ட் பண்ணலைன்னா, we will lose the patient. So last month we lost almost 3 cases. The final diagnosis was sepsis. I don't know, you presented so many guidelines. So எங்களுக்கு வந்து சிம்பிளாக என்ன அவைலபிள் ஆன்டிபயோட்டிக் இருக்கோ அதில் தான் we are prescribing. I think following, as you said finally, following simple hand hygiene and following aseptic precautions, especially patient on ventilator and patients with central line, that is very important than fighting with such dreadful organisms. And one more thing, hereafter we can involve the microbiologist also in selection of the antibiotic for critical cases. I think that's why they have been included in the OPS Red Alert group also. But the problem is most of the cases, the culture report is coming as negative for all organisms. We don't know what to do. Thank you for the detailed presentation, sir. Thank you.
Thank you, sir, for your elaborative and informative presentation. I have a strong doubt about your degree, sir. Apart from MD Microbiology, you have secretly passed MD General Medicine also. Because the talk was more like a physician rather than a microbiologist. Congratulations and thank you, sir. It will be more useful to our postgraduates. So many guidelines you have given there, especially the case-based discussion was interesting. All the cases are very much interesting cases. And coming to the madam point, so involving the microbiologist in selecting antibiotics is a very good job actually. Actually this treating infection is like running a joint family. You know how difficult it is to run a joint family. Suppose in a joint family a wife has decided to cook rasam one day. இன்னைக்கு ரசம் வைக்கணும் முடிவு பண்ணிட்டாங்க. உடனே தம்பியை கூப்பிட்டு வைஃப் இருக்காங்க, ஹஸ்பண்ட் யாருங்கிறத இன்னொரு இமெயிலில் பேசுவோம். ஸோ வைஃப் தம்பியை கூப்பிட்டு, தம்பி இன்னைக்கு ரசம் வைக்க போகிறேன், நீ போய் தக்காளி வாங்கிட்டு வந்துடு. தம்பி போய் கடையில் போய் வாங்கிட்டு வந்துட்டார். வாங்கிட்டு வந்து இந்தம்மா ரசத்துக்கு எல்லாம் ரெடி பண்ணி பேக் ஓப்பன் பண்ண உள்ள ரசம் இல்லை, கத்திரிக்காய். என்னடா இது தக்காளி இல்லை கத்திரிக்காய். தக்காளி இல்லைக்கா கத்திரி வாங்கிட்டு வந்தேன். ஸோ ஜஸ்ட் லைக் திஸ், wife is a physician, right? The rasam, keeping rasam is a treating infection. So a physician has decided to treat infection like UTI, and he will think that so UTI will respond to amikacin. He will start amikacin and waiting for microbiologist report. தக்காளி வரும் amikacin ஃபேவரா நினைச்சிட்டே இருப்போம். வர்றது கத்திரிக்காய். amikacin resistant ஒரு குண்டு தூக்கி போடுவார் சார். அவ்வளோதான், சோலி முடிஞ்சாங்க, ரைட்? So this will happen in all the rounds of physician, in day-to-day activities, day-to-day rounds, even in OPD, IPD. It's a very tough job to treat infection. We'll then think that this infection is amenable to gentamicin. We'll start and use, but the culture will be yielding a different result. So we have to consult the microbiologist even before selecting antibiotics and after selecting empirical therapy, and even after giving the culture to the microbiologist, you have to give some background information. So that is much mandatory, because the microbiologist does not know about the infection. So according to as per your information only, they will select the antibiotics for antibiogram. So that is the thing that I personally feel. And PGs are here. How many of you know about institutional antibiotic policy? Please raise your hand. Our institutional antibiotic policy, do you know it or not? Whether you are using whether you are referring the institutional antibiotic policy before choosing empirical therapy for any of the infection, even you are sitting in the OPD and you are seeing URI, are you using the empirical antibiotic as per the guidelines given by our Professor Jeyamurugan sir? Anybody knows that? Our institutional antibiotic policy? Nobody knows. See how much of pain sir has taken. Our Department of Microbiology has taken so much effort to develop institutional antibiotic policy, and they have implemented it. But no PG or no assistants, no department. Even in my department, I have how many number of times I have told my PGs, please use antibiotic policy. Institutional antibiotic policy is very much mandatory. So this resistance, sir has projected a nice slide of resistance, right? So 99% of resistance is by the treating physician only, not because of the infection. The organisms are not responsible for infection. We, the physicians, because of the inappropriate use of antibiotic, right? The dose calculation is wrong, the setting is wrong, indication is wrong, selection of antibiotic is wrong, so everything is wrong. So the organism will act bizarre. That is what is happening in nowadays. So this is a very good eye opener session. Thank you sir, thank you very much. And our respected vice principal is also a microbiologist, and she has visited so many conferences. So I think she may be able to give some input on antibiotic resistance. And I thank our Professor Jeyamurugan sir. Actually, I want to congratulate him. He is taking so much of effort in shaping this microbiology laboratory, in bringing all innovations to his laboratory, even during COVID period and post-COVID period. Even now, with his team, for good support from Nitya madam and Shankar sir. So he is doing a lot of wonders, which is not known to all the physician surgeons. So we have to make use of Jeyamurugan sir judiciously. So I request all the departments to follow institutional antibiotic policy in this day. So we will take as a pledge. உறுதிமொழி எடுத்துக்கலாம் நம்ம எல்லாமே. So thank you sir, thank you for the opportunity.
Sir, actually antibiotic policy, we conducted a department level meeting sir. Actually micro level meeting sir. We discussed all the clinical conditions, medicine side clinical conditions, what are the drug you are prescribing, and what are the standard guidelines mentioned the drug. So based on that we prepared a institution antibiotic policies. Actually, we conduct all the medicine, surgery, and then moreover initially we did that is conventional culture method sir. Actually we get only 20% here. But now we have advanced, that is thanks to our Balaji. Now we have righted everything, sir. So we will do better than the previous level. We can do better in the antimicrobial resistance aspect, sir. And definitely that access group program, that watch group program, that reserve group program, we have to use judicial That is more important. And while conducting this type of program, definitely it will be useful to the PGs and students also. Thank you.
Our HOD of Medicine told, I have recently attended the National Conference of IAM of Delhi last month. There also, previously they are talking about many genetic level like that. Nowadays, the only thing is antimicrobial resistance as well as antimicrobial stewardship program. As Sir told, this is not a single field of microbiology to combat the antimicrobial resistance. This is the whole hospital. All the clinicians should have correlation with the microbiology department, and we should do this antimicrobial resistant pattern as well as the antibiotic stewardship pattern. So what antibiotic to prescribe, we will have frequent meetings with the microbiology department so that only we can avoid this antimicrobial resistance. This is mainly due to the improper usage and the excessive usage of the antibiotics. So we are having a good machine, Vitec, newly given by our DME. As Sir is here, I want to recommend, please provide the kits also. We are having the machine, but not adequate kits. So we are not able to utilize the automated culture system. It is very useful one. We can get the results immediately as well as the sensitivity pattern with the genetic level, what this MBL, the ESBL, everything will be reported in this Vitec report. So it will be very useful for us to treat in future. Thank you for the opportunity.
Sir, respected Professor HODs of Medicine and OG, respected Professor of Microbiology who is arranging this antibiotic week, has been inaugurated by a brilliant lecture by the speaker. So all the clinicians are appreciating the microbiologist. Basically, he is a microbiologist. He is talking in clinical terms as pointed by our medicine HOD. So we, as a clinician, myself as a pediatrician, we tend to start, whenever there is a fever, we equate this with the infection, and we tend to start the child with antibiotics, and we fail to take the culture before starting the antibiotic, and we fail to review the prescription of the antibiotic based on the culture report. So we are ready to escalate the antibiotic, we are not ready to de-escalate the antibiotic. That is the basic problem. So our institution should have an antibiotic audit. So drug audit like antibiotic audit should be done by a neutral department so as to curb the inappropriate use of antibiotic, so that future generations of can be spared with this resistance, so-called menace of resistance. So we recently had Delhi crisis, அது மாதிரி எந்த இதுவுமே ஆன்டிபயோட்டிக் எதுவுமே ஒர்க் ஆகலைன்னா என்ன பண்ண முடியும்? ஒரு வெண்டிலேட் பண்ணிட்டு போகிற பேபியை எதில் ஆன்டிபயோட்டிக் ரெசிஸ்டன்ஸ்னா இமேஜின். So we should not lead to this problem. So we have to use this antibiotic in a judicious fashion based on the culture report as well as the clinical pattern. As he rightly said, some infection 100% needed an antibiotic, some infections doesn't need an antibiotic at all, and sometimes you have to start an antibiotic. So he has classified into 3 categories, and he has given a lot of scenarios. Right now, acute CNS infection, urinary tract infection, osteomyelitis, skin infection. So he has quoted all the infected endocarditis. All this has been widely discussed. I thank the speaker for his lucid lecture. I thank everyone for attentiveness. Thank you.
As said by everyone, starting with all the infections, a patient suffers, starting with meningitis to cystitis and urinary tract infections. He has covered the whole lot. What are the infections the patient may undergo and how to be treated. In between a slide has come about the studies and that year was 2015. That means still the older pattern we are following, I presume. So after that, no study has been done. I think, I don't know what is the latest guidelines, but you have given a good outlook of what is needed for the current scenario. So the thing is selection of the antibiotic, and as we came in the middle, okay, and how to select the drug and the dosage and the duration. This is very important. We have projected there, and that should be correctly followed, so that only the antibiotic usage should be used in a correct manner. So you have given a clear idea about for which this all the clinical departments should follow, and you should judicially. I think most of the time any sepsis, after giving all these treatments, we fail to save the patient. That is the outcome we are coming across on the late stages now, because of not following it perfect manner. So with the guidance of the microbiologists, I think this can be overcome, and it can be treated in an effective manner. It's a good lecture one, and thank you, sir. Thank you for coming and giving us the awareness. Thank you. Thank you.
Our dean sir will present today's speaker, Dr.A.V.M.Balaji. Merci Rodrigo ma'am, Professor and HOD.